Hello friends, welcome to my YouTube channel. Today we are going to discuss about a very important topic in pediatrics. This is very important for your clinical practice also and for exam point of view also. So let's begin. The topic of today is respiratory distress in a newborn. There are so many causes of respiratory distress, and first of all, how to suspect that a newborn is having respiratory distress or not. So for that, these five indicators come in handy. The first one is respiratory rate is more than 60 cycles per minute. If the newborn is having a respiratory rate more than 60 per minute, then you have to suspect there is a respiratory distress there or not. Then chest retractions are present, if grunting is present, if flaring of alanasia are present, or cyanosis is present. These five indicators tell us that there is respiratory distress present or not in a newborn. So whenever you see these features, then you have to suspect a respiratory distress in a newborn. How to approach a case of respiratory distress in a newborn? If the patient is having respiratory distress and the patient is preterm or premature or gestational age less than 34 weeks, then you have to suspect respiratory distress syndrome or hyaline membrane disease. Or if the patient is term, then you have to suspect transient tachypnea of newborn and respiratory distress patient plus there is history of meconium stained amniotic fluid, then you have to suspect meconium aspiration syndrome. Or if there is presence of excessive frothing along with respiratory distress in a newborn, then you have to suspect of tracheoesophageal fistula. Or if the patient is diagnosed with RDS and there is no improvement with surfactant treatment, then you have to suspect pulmonary alveolar proteinosis. Or if the patient is having respiratory distress along with scaphoid abdomen, then you have to suspect of congenital diaphragmatic hernia. So this is how you have to approach a respiratory distress in a newborn, and there are so many conditions apart from these six that I have mentioned here, but these six are very important, and we are going to discuss about these six conditions. Let us begin with respiratory distress syndrome. Respiratory distress syndrome is the most common cause of respiratory distress in a preterm neonates. Here basic defect here is a deficiency of mature surfactant. So what is this mature surfactant? What is it composed of? It is composed of DPPC. DPPC is very important component of surfactant, that is dipalmitoyl phosphatidylcholine, or simply called as lecithin. It's most important, and apart from DPPC, it is also composed of phosphatidylglycerol, cholesterol, surfactant proteins A, B, C, D, and among A, B, C, D, the B protein is most important, defect of which causes pulmonary alveolar proteinosis. And how this surfactant is synthesized, or when the surfactant starts appearing in a newborn lung. So the synthesis of surfactant begins in fetal lungs at around 20 weeks of gestation, and it begins to appear in amniotic fluid at around 28 to 32 weeks of gestation, and it mature surfactant in adequate amount is seen at around 35 or more than 35 weeks of gestation. Then what is the function of surfactant? Why it's so important? Because surfactant decreases the surface tension of alveoli, and it prevents alveoli from collapsing during expiration. What happens during inspiration? There is positive pressure distending the alveoli, and during expiration the air moves out from the alveoli, causing a drop in pressure. So because of drop in pressure, the alveoli tend to collapse, but this surfactant prevents alveoli from collapsing during expiration. That is the most important function of surfactant, and if the surfactant is deficient, alveoli will collapse and there will be dyspnea. So let us look at the pathophysiology of RDS. What happens? There is, of course, basic defect is decrease or deficiency in surfactant, and this causes alveolar collapse, and there is diffuse alveolar damage, and there is interstitial edema and fibrin deposition. All this mix up to form a eosinophilic membrane on a lung biopsy that is known as hyaline membrane, and this is how it looks like. Okay, this is your eosinophilic membrane known as hyaline membrane, and you can see collapsed alveoli in the lung biopsy. What are the chest X-ray features that are suggestive of RDS? In RDS, there is complete white out lungs. That is because of ground glass appearance of the lung fields, and you may see air bronchogram, that is air present in the bronchus and bronchioles, and sometimes you may find reticulogranular or reticulonodular appearance, and you may find features of lung collapse. This is the typical X-ray feature of RDS, complete whiteout lung. But how to diagnose this condition? This condition is diagnosed based on the clinical features. Preterm or premature newborn born with respiratory distress, then you suspect RDS. Then you can diagnose this condition by chest X-ray, or you can diagnose this by amniotic fluid examination. In amniotic fluid examination, a couple of tests are performed, and they are LS ratio. The important test here is LS ratio. If it is more than 2:1, it tells us that it is mature surfactant. Then you can estimate phosphatidylglycerol level, or you can do Nile blue sulfatase test, which detect lung maturity, and you can do shake test. If you find more than or equal to one complete ring of bubbles on surface, then it tells us that it is a mature surfactant. So after diagnosing how to treat these patients are treated with supportive care and specific treatment. What is the specific treatment here is, if the patient is having mild RDS, he requires, or the neonate requires only CPAP. And if the patient is having moderate RDS, you can go for intratracheal surfactant plus respiratory support in the form of CPAP or mechanical ventilation. Then we can prevent this condition. How to prevent this condition? Whenever the patient is suspected to, or the patient is expected to deliver between 24 to 34 weeks of gestation, you have to give her antenatal steroids. Antenatal steroids are given to all the pregnant ladies who are expected to deliver between 24 to 34 weeks of gestation, and the steroids used here are injection betamethasone 12 mg. 2 doses are given and 24 hours apart. The betamethasone is shown to have some neuroprotective action. This is the steroid of choice to give in a pregnant lady who is expected to deliver between 24 to 34 weeks of gestation. But the preferred drug in Indian scenario, the preferred drug here is dexamethasone, which is given in 4 doses, 6 mg, 12 hours apart. It is recommended because it is cheaper than the betamethasone. Okay, that's it for this video, and if you want me to cover any of the topic, please let me know in the comment section, and I will come up with that video soon, and the rest of the conditions will be explained in the next video. Thank you. All the best.